Hello everybody, we are Elena Rodríguez and Mathilde, editorial of the International Journal of Gynecological Counseling. We have the honor to interview today Professor Murat Gultekin from Ayatollah University Hospital in Ankara, Turkey, and Dr. Claudia Marchetti from Numeri Hospital in Rome, Italy. What is your recommendation about an oral contraceptive issue because of condition?
For homeopathic, we have to say that it is safe to give oral contraceptive for the non-oncological side effects. So we can give to our female HTTVs, of course. We have to consider and balance the risk, the reduction of risk of cancer from one side, but the possible breast cancer on the other side, because literature and analysis suggests that there is a 40-50% decrease of ovarian cancer, a similar increase of breast cancer, especially the nasal area. So from the question is, can I get pill or contraceptive? Overall, yes, when the patient desires for maybe for contraception, also for other gynecological nutrition. Should I receive oral contraceptive to prevent ovarian cancer? This should be the first reason. And especially patients they 40 or when they have completed the should be maybe when they have the age for receiving this surgery, it's better for them to receive this directed surgery, not for contraception. Although it was at that age, so in the 40s, of course in the 50s, the risk of breast cancer outweighs the benefit in terms of ovarian cancer reduction.
Let me follow up and comment on profilactic.
You know, what we have found in our consensus and literature is that if we want to screen this patient, it is an option, but it's not safe because data at this time are still lacking in terms of survival. So if we use the ultrasound together with the rock algorithm for the C125, so not the C125 registration, according to the rock algorithm, there will be a decrease in the diagnosis of advanced breast cancer and also improvement in terms of optimal cytotoxic surgery support or cancer identified. But there are still too many necessary surgeries, so it's not perfect. And also, superior data on this procedure are still bad. So this is not the best option. This is an option only for those women who want to delay surgery or a silent period, but they should be made aware that this is not the safest option.
Why do they feel not a contraceptive is a part?
What is about? The moment get not, and once I get the ban that the safety, we have to wait several years. Now, they tell me that we had, especially the suspected, or maybe he has some marker size of he has some attitude, but it's not so strong to suggest that routine practice is procedure. So the data that we have is for the critical capacity to chart framing and if I good or she can what you like. But my feeling is that before we can propose to our patient, we have to wait the definitive conclusion of the clinical trials. And wait, the bad news is that we have to wait for the trials to have the safety per oncological issue. But for the moment, it shouldn't be proposed. There are some patients that they want. In some cases, it's like a compromise. But once again, you should be well aware that we think that it may be an option, but you're still basic.
It's mainly for breast and so instead on tracking just what
Not it for the moment. I really cool. It was for instance in Mexico, we had the two goals. And you know, to be an honest, you need to have children, so you have some career to expect. And what I understand is that for this, the patient is really an option. So the fact that they can just a salpingectomy, maintain a follow function, and delay the oforectomy for these women is really a good option. So first of all, it's an opportunity for that to be well, but also to be really nice for that to have the chances to delay the menopause. So it would be fantastic to propose to our patient. But sometimes, yes, if you have not showed the origin of that cancer, so you know, subject to issue, so be careful.
Let me to talk about the endometrial cancer.
Contraceptive methods do you think that can be more appropriate in patients with Lynch syndrome?
Well, first of all, the first issue is the safety, and we have really very very limited data, and the great majority of the data comes, from the general population plus BRCA patients. For the Lynch syndrome, we have very limited data, but we read the whole literature, and I can say that the use of hormonal contraceptive, oral contraceptive IUD is safe in the Lynch syndrome scenario. But we know that they have a protective effect. If you are using IUD, then it's 60% risk reduction in endometrial cancer in the general population. And also combined oral contraceptive. We don't have the data for that in the list. So use of hormonal contraception is safe, but I cannot encourage you to recommend your patients just to prevent endometrial cancer because we don't have this data, sufficient data, but it's safe and you can.
Regarding oforectomy for a Lynch syndrome woman, what do you think about this?
It's one of the most debatable issue of this statement. There is no any consensus in the literature. It's definitely different guidelines recommend different things. For me, it depends on the age of the patient, fertility desire, morbidity of the patients, and how much as a surgery is difficult, and of course the hereditary variant. Not everybody is a standard Lynch syndrome, right? So if you are talking about, for example, PMS2 mutation, it's definitely that the endometrial cancer risk is a little bit high in the elderly after 50, and ovarian cancer risk is low. So you can offer an hysterectomy and oforectomy at age 50. But if you are talking about MLH1 or MSH6, there is a endometrial cancer risk, especially between 40 to 50. So hysterectomy should be done maybe at age 40. The ovarian cancer risk is low at those age 2 to 3%. If the patient accepts, you can offer an oophorectomy at the age of 50, not 40, for these two mutations. And the last mutation is MSH2 with the highest ovarian cancer risk. It's probably 8 to 10% between ages 40 to 50. And for this MSH2, I would definitely recommend a hysterectomy and oophorectomy at age 40. But also, don't forget, any type of salpingectomy even has a 50% risk reduction in these patients. If you are delaying the oophorectomy, at least you can recommend a salpingectomy during hysterectomy.
Last question is about follow-up. Follow-up, do you recommend before the age of prophylactic surgery? At what age can we start?
Well, first of all, in the Lynch syndrome, the main follow-up is colorectal surveillance, colonoscopy for colon cancer. Don't forget, it's the most and proven efficient preventive annual colonoscopy. For endometrial and ovarian carcinoma, unfortunately, the efficiency is very, very low, almost zero. I mean, because it's the nature of the disease. Usually in the endometrial carcinoma, they come with early stage with abnormal bleeding. And in ovarian carcinoma, we have BRCA patients that and usually we cannot detect it very early. But despite this data, we, ESGO and our experts still recommend surveillance. We start at the age of 30 and an annual ultrasonography with endometrial biopsy is the best way. So efficiency is low, but still you can recognize endometrial hyperplasia before cancer. You can still make a stage downing in the ovarian carcinoma. So in short, the data is not showing that it's not very efficient to make the surveillance. But after the surgery, we recommend to start surveillance at age 30 to 35 with annual ultrasonography and biopsy. Without biopsy, surveillance is not acceptable. Thank you.
Question. A woman that has more than 40 years old but he doesn't complete the reproductive desires. Can we do something to help to prevent the endometrial cancer if he doesn't want to do the surgery, prophylactic surgery?
Yeah, we should first of all inform her very importantly because nothing can replace prophylactic surgery. It's the gold standard. And of course, you can use some medical prevention if you are a skinny. I told you, combine oral contraceptive and hormonal IUD in the general population and even in BRCA patients as protective effect. But in Lynch syndrome, we don't have any data with the IUD. And in the Lynch syndrome, we don't have any data about the oral contraceptive. Only one data showing 1 year follow-up and risk reduction in 60%. So be careful, but you can recommend. Definitely, but you should recommend aspirin. 600 milligram per day is for risk reduction in colorectal cancer. Again, not ovarian and endometrial.
Okay. Thank you very much.
Thank you so much. Thank you.